Just give.
Hi everyone, my name's Matt. I'm from PVACCS. Very excited today to be welcoming you to the first of our ICU mini-series on shock. It's a pretty exciting topic, a pretty important one that I'm sure you'll all come across at some point, whether you're doing surgery, medicine, or one of the general stream rotations. So let's get cracking. To start off with, I'll give you a brief outline of tonight's event. So we're aiming to finish up by about 7:30. We'll be looking at the types of shock and running through the definition of those things, providing a few examples, and hopefully engaging you, the audience, during the chat. So Emma, who's talking, would like to get you guys involved. There'll also be opportunities for you to ask questions at the end through one of our links, and we hope you get a lot out of it. Before we continue, I'll get you guys to log on to Slido, just using that barcode. So if you type in any questions, we can address them at the end. As I said, Emma may also ask you to interact through the Zoom chat as well if she asks you guys questions directly. If you feel comfortable speaking, that'd be fantastic. We'd really appreciate that. I'd also like to take the opportunity to acknowledge country. So I'd like to begin by acknowledging the traditional custodians of the land that I'm on. I know we're all on different lands at this point, and I'd like to pay my respects to elders past, present, and emerging. And I acknowledge that sovereignty was never ceded. Moving forward, next up, none of this happens without our important sponsors, and the two sponsors for this event today are Doctor on Call, which is a locum agency, and we've all come across Avant Mutual. We've got Amanda from Doctor on Call who'd like to introduce herself and have a quick chat with you guys. Go ahead, Amanda.
Thanks so much for that. So my name's Amanda Harmon. I'm the Candidate Acquisition Manager for Doctor on Call. So Doctor on Call is a locum agency, and we place doctors in hospitals, public and private, throughout Australia, and also in special events and different clinics and that kind of thing. We were started in 2007 by 3 doctors, so they have a really good understanding of the locum market and what was needed at that time. So they wanted to start their own company to for their first-hand knowledge of locuming and deficiencies that they saw in the market at that point. We offer a personalised recruitment process where we work in with each individual doctor to ensure that we find jobs to suit your need, your experience, and also your financial expectations. We've got arrangements with a number of private and public hospitals across Australia. So no matter where you're located, there will be somewhere close by or even throughout interstate for you. If you were interested in doing locum work interstate, then there's plenty of opportunities for travel, with a lot of hospitals paying for accommodation and travel. So what we offer, we communicate with you on what accommodation and travel options are available. As I said, a lot of hospitals will offer travel and accommodation, so we'll work with you to organise all of that. We'll do all the compensation negotiations on your behalf as well. So if there's any issues with payroll after you've done a shift, then we'll follow all of that up to make sure that you're getting paid everything correctly. We'll negotiate all your shift days and times on your behalf as well. We look after all the invoicing and chasing up of payments. We'll send you targeted placement advertising. So if you're looking for RMO roles, we'll send you RMO vacancies. We won't send you consultant vacancies and that kind of thing. And we have a committed customer service team that's available 24/7. So no matter what the time of day, if you're going on a locum placement, if you've got an issue, then you can always give us a call and have a chat. The benefits that we offer, so this is where we're different from some other locum agencies. So we do have some really great incentive programs at Doctor on Call. The first is our performance boost. So for every 5 shifts you work up to 15 shifts, you'll receive a monetary bonus. So first 5 shifts, $400. Next 5 shifts, you'll get an extra $200. And the next 5 shifts will bring you up to 15. And that qualifies you for another $100. After that, you then go into our next program, which is a health check program, where we put all of our doctors that have done shifts in that quarter into a draw for $5,000. So one of our doctors wins $5,000 each quarter. And the third program is refer a friend. So anyone that works for us, any of our doctors that has a friend or a colleague that's interested in locuming, if they sign up as well and do at least 1 shift with us, then we'll give you a $500 gift card. Now, the only condition on these is that there's no cancellation in the qualifying periods. So where to start with this to begin your registration, there's a QR code on your screen at the moment. So anybody that has any interest in locum work, even if you just want a little bit more information, just scan that QR code and pop your details in, and then I can get in touch and have a bit more of a chat to you about it. There's no obligation if you're just wanting a little bit more info than what I can give you in this time frame tonight. Just scan that QR code and I can give you a call later in the week and have a bit more of a chat. To start with, all we need is your CV and minimum 2 referees. So it's pretty easy to get started. That's all we need. You don't have to go through and do all the registration forms until you're ready to actually start locuming. And I'm available 24/7 to assist with any of the onboarding process. So any questions at all, then you can always let me know. So that's pretty much it from me. As I said, if you're interested, scan that QR code now and I can get in touch and have a bit more of a chat. I hope you all enjoy your training course tonight, and I'll leave you to it.
Thank you very much, Amanda.
No worries at all. Thanks for the opportunity.
Thank you.
Okay, bye.
Bye-bye. Okay, so I think we'll get cracking right now. So the topic for tonight, as you all know, is shock. Very important. I'll let Amanda take it away. Just quickly give her an introduction. She's an ICU registrar from the Northern Hospital. She has quite extensive experience in a number of fields. She previously went through the surgical pathway before finding her way into critical care. She has worked in a number of hospitals and has a very strong social conscience. So I'll let Amanda take things from Emma take things from here. Excuse me. Thank you.
Thanks, Matt. And hi, everyone. Thanks for coming along tonight. I'll just figure out how to share my slides and then we'll get started. So it's just saying that I can't share my screen there. It's just saying host disabled participant screen sharing.
Yeah, go again. I've just made you co-host.
Thank you. There we go. Okay, so can everyone see my slides there?
Yep.
Yep, I'll just see if I can put them into slideshow mode and see if it works. I know sometimes it doesn't present very well. How does that? Is that all right?
Looks good.
Excellent. Okay. So as Matt said, I'm an intensive care registrar, PGY 8 this year, and currently working at the Northern Hospital. And I'll be talking to you tonight about circulatory shock. Just a bit of a disclaimer there. I am not an expert in this field. I'm obviously a registrar, still in my training. And these views that I'm presenting tonight are based on my knowledge from my accumulated experience, working as a doctor and managing patients with shock and everything that I've learned from my supervisors. But you will encounter many different approaches across the different places that you work, as well as different policies on managing patients and different procedures and everything like that. So every time you learn something, I think as you're developing as a doctor, you should always take it on board and then find a way to make it your own and figure out how you work best. So there'll be things from this that you take away and other things that you think, that doesn't really fit with my experience. And you'll find your own way of doing things over time. So this is just my recommendations and it's pretty general stuff, but yeah, that's just to say that. The other thing I just want to say is this is a safe learning space. So what that means is that it's a judgment-free zone. Anything that you say in this session or any questions that you ask, there isn't a dumb question. Everybody has a different level of knowledge and learning, and all questions are welcome during this session. And the other thing is to say that if somebody asks a question and you think to yourself, oh, that's a bit of a silly question, or I think my knowledge is a bit more advanced than theirs, that's not something that you go about sharing with other people. So anything, that comes up during this session, it stays in this session and we don't go and talk about what our colleagues have said or asked to other people. Everybody's on their own learning journey. So this is a safe place for everybody. And I just want you all to keep that in mind. If you are going to answer questions or ask questions, just be nice to everybody. Okay. So what we're going to cover in this session. So first we're going to talk about what is shock and go over a bit of the physiology of shock and the types of shock that you might encounter in your daily practice. Then we're going to look at ways to identify shock in practice, and particularly focusing on sort of the emergency situation where you might be called to see a patient at a MET call or be seeing a patient in the emergency department. The management of shock, both the sort of initial stabilization and also what are some more advanced management methods for shock. And then looking at a couple of case studies at the end. And there's no trick questions with the case studies. It's just a matter of trying to apply a little bit of what we've talked about. Okay. So we're going to start with what is circulatory shock. And I'm keen for you guys to put up your hand and give me some words that you think might describe shock, or words that come to mind when you think of a shocked patient.
So we've got someone saying low blood pressure.
Yep, hypotension, absolutely.
Tachycardia.
Yep.
And hypovolemia.
Yep, definitely.
A few things about end organ dysfunction from hypoperfusion.
Yep. So I can see already that you guys have a fair bit of knowledge about shock, which is fantastic. So I think you've sort of hit the nail a bit on the head. But I suppose the thing that I want to get across to you, what part of this talk is about, is the fact that whilst we all sort of have an idea in our minds of what shock is like, none of the singular characteristics necessarily define everybody with shock. And they're certainly not universally true of patients with shock. And the other thing to think about is the fact that by the time some of these common characteristics are evident, you might have missed the boat for that early recognition and early treatment for a patient who's developing shock. So really, shock is not a homogeneous disease. And whilst some patients will present with hypotension, some patients will present with a normal blood pressure but still be shocked. While some patients will present with an elevated lactate, not all patients with shock will have an elevated lactate. Some of you might have thought, you know, a patient who's shocked is the type of patient that I would describe as like a deteriorating patient, or a patient who looks generally unwell or is on a downward spiral. But some of these things can be subtle. And like I said, sometimes by the time the patient looks really unwell, it's a bit late and you've actually missed the opportunity to make an early diagnosis of developing shock. And the other thing to say is that some of that downward spiral is preventable if we do make an early diagnosis of shock. So this kind of gets to the question of, why is it clinically useful to diagnose shock? Why do we have this syndrome called shock that we like to diagnose patients with? What purpose does it serve in our clinical practice? And I think for me, the most important thing is that when you say this patient is shocked, everybody has a global understanding that shock is a serious condition, and it brings everybody in the room and everybody caring for that patient onto the same page to say this patient is really unwell and they need urgent treatment, and we need to prioritize the treatments that we're giving them to make sure that we can start to reverse this process. One of my favorite ways of describing shock is that it's the final common pathway before multi-organ failure and death. So all diseases, as they deteriorate, will ultimately end up as shock before they end up as multi-organ failure and result in death. So it's really important that we do diagnose shock so that we, A, realize that the patient is really sick, and B, everybody can get on board with the fact that the patient needs urgent treatment. So talking a bit more about how we define shock in clinical practice, there's not really one definitive definition of shock. But these are sort of the most commonly recognized or agreed upon definitions. So shock is a failure to deliver and or utilize adequate amounts of oxygen in the peripheral tissues. Or you could also describe it as shock being the clinical expression of circulatory failure that results in inadequate cellular oxygen utilization. AKA what we're trying to say here is that shock is the failure of the aerobic metabolic system that powers the cells and organs of the body that we all had to learn about in our physiology and biochemistry study. So it's really important that we realize that shock focuses on this idea of oxygen delivery. Even though we won't talk, as we go further into this talk, we won't be talking a lot about oxygen delivery itself. It's important to have a bit of an understanding about how that underpins the idea of shock. And we'll go through some of that normal physiology in a sec. As I said before, importantly, shock can present both with a low blood pressure and low cardiac output state, but can also present with normal blood pressure and high cardiac output. And that's where we come back to this idea that it's the oxygen delivery that has failed, not necessarily the cardiac output or the blood pressure itself. So looking at that physiology of oxygen delivery to the organs, this is the oxygen delivery equation. I don't expect you guys to know or remember this yet until you're thinking about sitting primary exams and that sort of thing. But essentially you can see here that the delivery of oxygen, and this is to the organs or peripheral tissues, is dependent on cardiac output, as well as how much oxygen is carried by hemoglobin, which is what's in that sort of first set of brackets, and the partial pressure of oxygen in the blood, which is in that second set of brackets. Therefore, we can see that cardiac output must be maintained in order to ensure adequate oxygen delivery, but it's not actually as simple as that in terms of normal physiology. And that's because the circulatory system doesn't actually directly monitor cardiac output. Instead, it regulates our MAP, our mean arterial pressure, to ensure adequate oxygen delivery across a range of cardiac output and systemic vascular resistance states. And the organs themselves actually auto-regulate their blood flow when the MAP is within a normal range. But that system actually fails when the MAP falls outside of the normal range. So in particular, we know that for most organs, when the MAP falls below 50 millimeters of mercury, and we're talking about the mean arterial pressure, not the systolic blood pressure there. When the MAP falls below that 50 millimeters of mercury point, that's when those auto-regulatory systems of the organs fail, and they're not able to maintain their normal level of blood flow, and therefore not able to maintain their normal oxygen delivery to that organ. Therefore, we can see that it's the maintenance of the MAP that is a critical function of the circulatory system. By maintaining the MAP within the normal range, we can maintain it within a range where the organs can auto-regulate their blood flow and oxygen delivery and get just as much oxygen as they need. Some equations for you here. So the mean arterial pressure is equal to the cardiac output times the systemic vascular resistance, plus the right atrial pressure, which I've put in brackets because it's usually around 0. And breaking this down a bit further, we know that the cardiac output is equal to the stroke volume times the heart rate. Breaking this down even further, we know that the stroke volume is determined by preload, which is largely determined by the blood volume and blood return to the heart, the contractility, or how powerfully the heart is contracting, and the afterload, or the pressure against which the heart has to contract. And we know that the systemic vascular resistance is determined largely by the radius of the resistance arterioles. So looking at all of these equations, we can see what elements make up that MAP. It's about the cardiac output, which is the preload, contractility, and afterload, as well as the heart rate, and then the systemic vascular resistance, which is determined by that radius of the resistance arterioles. We know that in normal circumstances, compensatory mechanisms kick in when the MAP falls. So MAP homeostasis occurs via the baroreceptor reflex, which I'm sure you're all very familiar with, as well as some chemo and stretch receptor reflexes. So whenever we get a fall in the blood pressure, we get the baroreceptor reflex kicking in, we get central integration of that reflex, and then we get this sympathetic nervous system response with an increase in catecholamine release, and those catecholamines then act on the heart, on the blood vessels, and on the kidneys to achieve certain changes in the physiology in order to return the blood pressure back to normal. And those things can be fluid retention, increasing the preload, increasing the contractility of the heart directly by the action of the catecholamines directly on the heart, increasing the heart rate, and then veno and vasoconstriction to increase the systemic vascular resistance. And you can see how all of these responses to that baroreceptor reflex then come into this equation that makes up the MAP. And you can see how by altering those things, we improve our MAP back into the normal range. It's important to know that with advanced age, though, with cardiovascular, autonomic diseases and medications, that this normal compensatory mechanism might be altered. So for example, patients taking beta blockers might not be able to increase their heart rate in response to a fall in blood pressure. And so some of these auto-regulatory or compensatory mechanisms are not necessarily normal in all patients. talking about the shock state, so that was the normal physiological state and the normal response to a drop in blood pressure. But in shock states, you get to this point where these compensatory mechanisms are overwhelmed and they're insufficient to maintain adequate organ perfusion, okay? Then what you get is inadequate oxygen supply to the organs, and as a result, a shift to anaerobic metabolism. That results in reduced efficiency of ATP production, because we know that anaerobic metabolism is not as efficient as producing ATP for the cells. And so then you get progressive cellular and organ dysfunction. From this, we then get our clinical signs of hypoperfusion and organ dysfunction, and ultimately this leads to cell injury and death if it's not reversed. Early treatment and support for patients with shock is crucial to preventing this worsening organ dysfunction and this cycle towards death. Okay, so it's really important that we understand that physiology that underpins normal compensatory mechanisms for a fall in blood pressure, and then what occurs in the shock state, which is where those compensatory mechanisms are overwhelmed. Now we're going to have a bit of a look at the different types of circulatory shock. So I'm sure none of this is new to you guys, but there are 4 major types of circulatory shock that we're going to talk about. They fall into the categories of hypovolemic shock, so that is inadequate blood volume to meet circulatory demand. Cardiogenic shock, which is failure of the pump or the heart to produce inadequate cardiac output. Obstructive shock, which is an obstruction to blood flow anywhere along the circuit. Distributive shock, which is reduced systemic vascular resistance, altered autoregulation of that blood flow to the organs, and altered oxygen extraction at the level of the tissues. All other types of shock that you might know about, like anaphylactic shock or septic shock, are all manifestations of one or more of these categories. And we'll go through some examples of each type of shock when we talk about the types of shock in a bit more detail. It's important to notice as well that there are other non-circulatory causes of inadequate oxygen delivery or utilization that we're not going to cover in this talk, but they are things like severe hypoxia, independent of changes in the circulatory state, severe anemia that impairs oxygen delivery, histotoxic diseases, so that's where there's mitochondrial toxicity and actually the mitochondria can't utilize oxygen normally. And then high demand states where the demand for oxygen in the tissues is greater than the ability of the cardiovascular system to supply that amount of oxygen. We're going to talk a little bit first about the basic assessment to differentiate shock states from one another, and then we're going to talk in a bit more detail about the 4 types of shock, okay? So for each type of shock, there is an underlying pathology that has become so severe that has overcome those normal compensatory mechanisms that we talked about and has resulted then in impaired oxygen delivery. And there are many common signs among the different types of shock, but there are some key differentiating signs that you should be looking for when you're examining these patients. And those are, is the patient cold or warm peripherally? Is the patient clinically dry or clinically wet? And is there a presence of specific signs that would indicate a particular subtype of shock or a particular etiology of the shock that's going to point me in the direction of which type of shock this patient has? In addition to that, there's going to be specific investigations you can do. And again, some of these are going to be common to all types of shock, and some of them are going to help you to differentiate between different types of shock. So all forms of shock are going to potentially lead to organ injury in the liver or the kidneys, as well as in the heart. And so you might find abnormalities on those blood tests, and that could just indicate a general shock state, but it doesn't necessarily help you to differentiate between the different shock states. Hypoperfusion indicated by an elevated lactate, again, is common among all the shock states and might not necessarily help you to differentiate. And again, acidemia might indicate the severity of shock, but won't help you differentiate. Then there's other more specific investigations that we'll talk about when we talk about the different types of shock that will help you to differentiate specifically between the different types. When you're initially trying to basically assess a patient with shock and start to differentiate between those different states, you want to be doing your ABCD approach. So airway, hopefully not, hopefully intact and not too related to our assessment for shock. In terms of breathing, you want to be looking at the respiratory rate and the oxygen level of the patient and whether there's any work of breathing. Again, it's very common for patients with shock to have an elevated respiratory rate and may have increased work of breathing, but it won't necessarily help you differentiate between different types of shock. On the cardiovascular system, you want to know what the heart rate is. Obviously, you need to know what the blood pressure is. But importantly, to differentiate, as I said, it's really important that you're looking at the volume state and the JVP of the patient. You want to feel their pulse to see how strong it is. You want to check their capillary refill and see what's their peripheral perfusion like. And then you want to assess their peripheries for temperature and signs of mottling and poor perfusion. Under D, you want to be looking at the patient's GCS. It's very common for patients with shock to have an altered conscious state or altered mental state as a result of brain hypoperfusion. So again, unlikely to help you differentiate between the types of shock, but will help you to identify shock itself. And of course, don't forget glucose. Under E, which for me is environment, you want to be looking at the temperature. Is there a fever that's going to indicate a potential source of shock? Or is there a source of bleeding or infection that I can see when I expose the patient? Under F, which I use for sort of fluid or fluid balance, as well as urine output, you want to be looking at those things. And then G, which I use as gastro. Different people have a different sort of approach to examination, but this is my general approach to examination. So G, you want to be looking at GI input and losses, particularly does the patient have a high output state like diarrhea, vomiting, or high stoma losses? Or is the abdomen a source of bleeding or infection when you examine it? So that's sort of a general approach to starting to think about how we might differentiate between shock states when we're examining the patient, but we're going to go into the individual shock states now and talk a little bit more about those. Does anyone have any questions before we get into it? That's the other thing. If anyone has any questions at any point, just yell out or pop them in the chat. I'm happy to answer them as we go. All good. All right. So we'll start off with hypovolemic shock, a very common form of shock and probably one that you will encounter many times in your working life. And in terms of the pathophysiology of hypovolemic shock, we're talking about patients with a low blood volume. That results in a decreased preload and stroke volume. And as we identified, that preload and stroke volume is key to cardiac output and therefore a key component of the mean arterial pressure. That low cardiac output state results in impaired organ perfusion. Some cases some examples of the sorts of patients that might present with hypovolemic shock, we're talking about either patients with really low volume input. So that might be patients who have prolonged fasting states, for example. Patients with really high or excessive output states, so diarrhea, vomiting, high output stoma losses, patients with burns who have a lot of insensible losses, patients with pancreatitis or other conditions that result in third spacing of fluid out of the vascular space and into the interstitium, patients with polyuria, like type 1 diabetics presenting with diabetic ketoacidosis who've been very polyuric for a while, and febrile patients who have fevers over 39 or 40 degrees for multiple days, have really high insensible losses from sweating, and as a result can become quite shocked because they have such low blood volume as a result of those losses. And then finally, the obvious one, which is hemorrhage. So hemorrhage of any cause can cause hypovolemic shock. For example, traumatic injuries, GI bleeding, surgical bleeding, bleeding due to a coagulopathy, so like retroperitoneal bleeding, or vascular injury causing bleeding. Specifically, when we're looking at hypovolemic shock, so looking at some of those physiological variables, so we would expect our JVP, representing our preload, to be low. We would expect our cardiac output, were we to measure it, to be low. We would obviously expect our MAP to be low, but again, sometimes in the first or early stages, the blood pressure won't be that low. We would expect our systemic vascular resistance to be high, and that's a result of those compensatory mechanisms that we talked about. Because the blood pressure and the cardiac output are on the low side, the body compensates by increasing the systemic vascular resistance to try to protect the blood pressure and increase the perfusion to the organs. What this results in is a cold patient when you feel them with a prolonged capillary refill. You would expect the heart rate to be high. So again, that tachycardia is a compensatory mechanism for the low blood pressure, low cardiac output state. And it's really common for patients who develop hypovolemia to then present in AF. So any patient who has a pre-existing history of AF or is potentially prone to AF, well, often that will be the first sign that they're unwell, is that they'll present with AF, and you'll have to go looking for why have they developed AF. And sometimes it'll be as a result of hypovolemic shock. And then respiratory rate is a very sensitive marker of a patient who's unwell, but it's not very specific. So the respiratory rate might be high in any patient with shock, or if you get to that patient very late in the game, then it could be low because they're already in that sort of pre-terminal phase. In terms of clinical signs for hypovolemic shock, so this is a shock type that presents as a cold, pale patient. They will be clinically dry when you assess them. So again, that low JVP, they won't have edema usually. When you feel their pulse, it'll be thready, indicating that low cardiac output state, and they'll have this prolonged capillary refill time. As we mentioned, they're likely to have an altered mental state, particularly more severe cases of shock, and oliguria, so a low urine output. Key investigations for patients with hypovolemic shock. So whilst some patients with hypovolemic shock are hypovolemic because of hemorrhage, so you would expect a low hemoglobin, patients who are not hemorrhaging and have hypovolemic shock for some other reason might actually have a high hemoglobin because of hemoconcentration, because they're so dry. If they do have hemorrhagic shock, then it could be as a result of coagulopathy. So you want to be looking for that on the bloods. Do they have an elevated INR or a very low fibrinogen? AKI is very common among patients with shock, and in particular with either GI hemorrhage or patients who are extremely dry, you might see a very high urea. On the blood gas, you might be looking for a high lactate, a high potassium if the patient has an acute kidney injury, and again, checking to see what the hemoglobin is. If you're to do a bedside echo, you might see empty ventricles and the IVC might be collapsing. So those are sort of some of the key features of hypovolemic shock that you want to be looking for. The next type of shock that we want to talk about is cardiogenic shock. So you won't see this one as commonly, but when you do see it, you're not going to forget it. It's very distinctive. And in particular, if you're working on a cardiology unit or in the emergency department, particularly in the resus phase, you will see patients with cardiogenic shock. So this occurs as a result of either decreased contractility, arrhythmia, or diastolic failure of the heart, resulting in a low cardiac output state and impaired organ perfusion as a result. Some examples of pathologies that lead to cardiogenic shock. So anything that impairs cardiac contractility, so that might be cardiac ischemia, resulting in regional wall motion abnormality, any type of cardiomyopathy or long-standing heart failure that has an acute exacerbation, or other conditions that are commonly talked about at the moment, things like myocarditis. Any type of arrhythmia can result in cardiogenic shock because the cardiac output is impaired as a result of the arrhythmia. So that can either be a tachyarrhythmia, in particular so fast that it impairs diastolic filling time so that your stroke volume is very low, and as a result, your cardiac output is very low. Or a bradyarrhythmia, where the heart is simply going too slow to produce sufficient cardiac output over time to supply the organs with sufficient oxygen. Valvular diseases and acute valve rupture can also present as cardiogenic shock. Patients taking negative inotropic agents, so drugs that actually reduce cardiac contractility, like beta blockers or calcium channel blockers, particularly in overdose, can present in cardiogenic shock. And right heart failure. So patients with an exacerbation of chronic pulmonary hypertension or right heart ischemia can present with right heart failure and cardiogenic shock. Some of the key physiological variables, so you'll see that a lot of these are very similar as for hypovolemic shock, except one of the key differentiators is that you would expect your JVP to be high. And that's as a result of that poor cardiac output state. but with a normal circulating blood volume. So you'll get obstruction of venous return because there's not enough cardiac output. And so blood is sort of backing up in the system. And so you'll see that high JVP rather than the low JVP that you see in hypovolemic shock. But you'll still have a low cardiac output, low MAP state, and that high systemic vascular resistance and high heart rate trying to compensate for those. And again, you might see a tachypnea that's not very specific. Other clinical signs, so these patients, unlike the hypovolemic patient who will look dry to examine, these patients are likely going to look wet to examine unless you get to them very early before they've had a chance to develop either pulmonary edema or peripheral edema. These patients generally will have either creps on the lungs or edema in the peripheries. And that's an important sign to identify. These patients will be cold, they'll be pale, and often they'll be quite significantly mottled in the peripheries. And again, they'll have a thready or sometimes an irregular pulse if they're in a tachyarrhythmia. That prolonged capillary refill time is common with hypovolemic shock, and again, an altered mental state or oliguria indicating that poor organ perfusion state. In particular, patients with cardiogenic shock often look diaphoretic, grey, and they might be complaining of chest pain. So that's a really important sign to pick up on. If the patient is hypotensive and diaphoretic, that's a really concerning sign. And then, of course, if they complain of chest pain, you want to be very concerned about that. Some key differentiating bloods for patients with cardiogenic shock. So in particular, you're going to be looking at those cardiac enzymes, elevated troponin and BNP. And again, it's very common for patients in cardiogenic shock to have an acute kidney and acute liver injuries. Again, they might have a high lactate or an acidemia, but that's not very specific. The echo is the real differentiator here. So you need someone who's capable of doing a bedside echo to see if you can see signs of impaired systolic function. And always an ECG to make sure that you've ruled out an acute myocardial infarction, which might present as STEMI or ST depression or T-wave inversion or a new left bundle branch block. All right, so the next type of shock is obstructive shock. And this one, you're not going to see that frequently, but when you do, it's probably because the patient is really very sick. So the pathophysiology for obstructive shock is an impaired cardiac output due to obstruction of blood flow or cardiac filling, resulting in a low cardiac output state again and impaired organ perfusion as a result. Obstruction in obstructive shock might be within the cardiac chambers themselves, might be within the arterial system, or might be something externally obstructing the cardiac chambers and preventing them from filling normally. So some examples of this would be embolisms. So in particular, the most common one is pulmonary embolism, which all of you will see at some point during your career. But the other ones are amniotic and fat emboli. Intracardiac obstruction from intracardiac thrombus, valve occlusion due to thrombus, or left ventricular outflow tract obstruction, less common and more likely to be seen on specialist cardiology units. Pericardial obstruction, so that might be due to pericardial effusion resulting in cardiac tamponade or a restrictive pericarditis. External compression from the respiratory system, so that might be due to tension pneumothorax, compressing the cardiac chambers, or dynamic hyperinflation, such as in severe asthma. And then finally, IVC compression, so caval compression by, for example, an at-term pregnancy might obstruct venous return to the heart and as a result, reduce cardiac output. Looking again at those physiological variables, so in obstructive shock, similar to cardiogenic shock, you would expect a very high JVP, and it's one of the cardinal signs that you should be looking for. You're going to be in a low cardiac output, low blood pressure state, but in particular, some of the more sensitive signs for obstructive shock would be this narrow pulse pressure and evidence of pulsus paradoxus. Systemic vascular resistance, again, is going to be high and heart rate is going to be elevated, both of these to compensate for that low cardiac output, low blood pressure state. Again, you might see tachypnea, in particular with certain conditions that cause obstructive shock like pulmonary embolus. You would expect the patient also to be quite hypoxic. Some of those clinical signs. So these patients might not clearly be dry or wet. They might look more euvolemic to you. And so obstructive shock should be in the back of your mind as a differential diagnosis when you see a patient that looks like maybe they have cardiogenic shock, but then they don't really have pulmonary edema or they don't have peripheral edema. The patients are likely to be cold or clammy. Again, they'll have that prolonged cap refill, altered mental state, and oliguria of impaired organ perfusion. And again, these patients, like in cardiogenic shock, are likely to look diaphoretic and grey and not very well when you see them. Blood, so the specific one you'd be looking for if you were thinking about PE in one of your patients would be the D dimer, but again, they're likely to have liver and kidney dysfunction. In the gas in particular, you might see hypoxia and hypercarbia if they do have a respiratory cause, for example, in the tension pneumothorax or the pulmonary embolus. Echo can be a good differentiator again here, showing a pericardial effusion and tamponade physiology or signs of RV, pressure or volume overload in the case of pulmonary embolus. And the ECG, again, is a very important differentiator here because if the patient has tamponade, you might see electrical alternans, which is where you see alternating heights of the QRS complex, one to the next on the ECG as a result of the heart essentially moving around in that sac of fluid. Or in the case of PE, you might see that S1, Q3, T3 pattern or signs of right heart strain. The final one that we're going to talk about is distributive shock, and this is the one that is most different from the others, and so most easy to differentiate, I suppose, which is lucky because it's also the most common. More than 60% of patients with shock on most studies have distributive shock, and commonly that is septic shock. So this is something that you guys are going to see really frequently in your practice, and it's really important that you're able to identify it. So the pathophysiology with distributive shock is quite different to the other ones, and it can be a little bit challenging to get your head around, but essentially what happens is you get a shock state due to usually a toxic type of insult. So that might be an infection or a toxic shock itself, or some other pro-inflammatory condition. As a result of that, you get this dysfunction and dysregulation of the peripheral system, resulting in a low systemic vascular resistance, dysfunction of those autoregulatory mechanisms that maintain organ blood flow and perfusion, altered oxygen extraction at the level of the tissues themselves, and altered oxygen utilization. And it's that combination of things, rather than necessarily a low cardiac output or low blood pressure state, that result in inadequate organ perfusion and oxygenation. So it's clear that this is quite different to the other forms of shock, where largely it's about that low cardiac output state resulting in impaired organ perfusion. This is more about there may be adequate cardiac output, but it's not able to get to the organs appropriately, and that oxygen is not able to be used appropriately due to the inflammatory state. So examples of distributive shock states, so septic shock, toxic shock syndrome, systemic inflammatory response syndrome, or another condition that we sort of call vasoplegic shock, which just generally means vasodilatory shock. And those can occur in the setting of post-major surgery or post-cardiac arrest, or any other major insult to the body can result in a pro-inflammatory state that results in a distributive shock picture. Anaphylactic shock is a form of distributive shock and is particularly differentiated from the other forms of distributive shock by the presence of a rash, an itch, or a wheeze. And of course, there needs to be some sort of agent that might have caused the anaphylaxis. Neurogenic shock is a form of distributive shock as well, and this is also sometimes described as autonomic shock or the loss of sympathetic tone, which might be due to spinal cord injury or spinal anesthesia. And that's differentiated by a vasodilated but bradycardic state, because there's that loss of the sympathetic tone to the heart that causes a tachycardia. So even though the patient is vasodilated and might have a low blood pressure, they're not mounting a tachycardia, they're actually bradycardic. And then adrenal and thyroid insufficiency are also forms of distributive shock. Ooh. So physiological variables associated with distributive shock. So like with hypovolemic shock, you might expect to see a low JVP and the patient might appear to be dry. But if you would actually measure their cardiac output, you might find it to be normal or even high normal or even very high compared to the standard person. And here we see that major differential with the other forms, which all present with a low cardiac output state. Despite the high cardiac output, though, the MAP might be low. And that's because we saw that the MAP is determined not only by cardiac output, but also by that systemic vascular resistance, which is low and dysfunctional in distributive shock. The heart rate likely to be high, except in those specific cases like neurogenic shock, where you might have a bradycardia. In other causes of distributive shock, usually there'll be a tachycardia as a compensatory mechanism. And again, patients who have a predisposition to AF will commonly present in AF as a result of a distributive shock state. So they might present with an infection and AF, and the AF might distract everybody from the fact that there's actually a septic shock going on. Again, the respiratory rate might be high, or if you're too late to the party, it might be a bit on the low side. So these patients are dry, and to differentiate them from all the other types of shock, these patients feel warm to the touch. They'll often be febrile, or they might actually be on the hypothermic side, so patients with a temperature in the 35s, you might want to be thinking about distributive shock. They might have a bounding pulse, but that's not necessarily true. Again, they will still have those signs of altered organ perfusion, so altered mental state and oliguria, indicating that those organs are not adequately perfused or oxygenated. In terms of investigation, some differentiating things would be a high white cell count and CRP, and any positive cultures the patient might have had. The echocardiogram, you might see actually what appears to be a hyperdynamic cardiac state, so a hypercontractile heart, trying to compensate for that dysregulated systemic vascular resistance. And you're unlikely to see any specific signs on an ECG. So those are our specific types of shock. And now I want to move into sort of what this all means in practice and how you would actually identify the shocked patient in practice and what sort of things you can do at the bedside. So the most important skill I think you can learn as a doctor, and obviously I'm biased because I'm an intensive care registrar, but I think the most important skill you can learn as a doctor is to be able to tell a sick patient from a not sick patient. It's a really essential skill that you should develop over your first few years of working. You should be able to walk into a room and look at the patient from the end of the bed and say, that person is sick, or I think that person's not too bad actually. When you're starting to learn this skill, it's something that can be done usually rapidly within the first sort of 5 minutes of presenting to see the patient either at a met call or maybe in the emergency department. And it should be based on a rapid assessment of their history, examination findings, and key investigations. History is really key. I think it's very easy when you go to a met call or something like that to just like not bother asking any questions about the history, but actually history is really important, and it's very important to go through the person's past medical history, what drugs they might be on either before or during their hospital admission, how they presented, what the time course of their illness is, and how acutely their clinical state is changing. Because these will all give you clues as to whether the patient is rapidly deteriorating, whether they might have an acute exacerbation of an underlying chronic condition like heart failure, or whether they might have drugs on board that are masking the signs of shock, for example, beta blockers preventing a tachycardia. I've said pay it forward here because I think good documentation is essential. And so it's really important when you turn up to a met call, you want to be able to flip back through the notes and quickly see what the history was at the presentation, what the patient's past medical history is, what's happened during the admission so far. And so it's really important that you guys, when you are working, are documenting those things clearly so that when when somebody else turns up to a met call for your patient, they can look through your notes and quickly see what's been going on, and you can do the same when you go to their patient's met calls. Examination is obviously essential, and I think, do not delay examining the patient. If you're the first person to turn up to a met call or to see a patient in the emergency department, you should be starting to practice doing history and examination together at the same time. So you'll often notice if you turn up to a met call and the Gen Med registrar or the intensive care registrar walks in, often the first thing they'll do is they'll go up and they'll touch the patient's hand or foot, and they might say hi to the patient. And they're not just doing that to be polite. What they're actually doing is they're immediately assessing, is this patient cold or warm? And is this patient able to respond appropriately to me saying hi to them? And so immediately they're getting feedback and information about what's the patient's circulatory state like, and are they perfusing their brain? That's sort of part of the end of the betagram of, is this patient sick in appearance? Do I walk into the room and I see a patient who's drowsy, diaphoretic and mottled? Or do I walk into the room and see a patient who's alert, talking to the nurse, and able to tell me that they went and had a wee 5 minutes ago? Obviously, you should be structuring your examination around the doctor's ABCD structure. So again, it's that immediately establishing, is the patient responsive and what is their ABC status? Because this will guide how rapidly you need to escalate or start treatment. IV access is a part of C, so the cardiovascular part of the examination. If you're the person who arrives first and you're starting to examine the patient, as soon as you've had a quick listen to their breathing, you should be checking to see not only what is their heart rate and their blood pressure, but do they have any IV access? And if they don't, it's important to establish that early. I've put don't ever forget glucose there because I'm terrible at this. I always forget glucose. But don't ever forget glucose, and also temperature, and make sure you are checking to see if the patient is febrile. The vital signs are obviously key. That's why our nurse is monitoring them all the time. And it's very easy to walk into a Met call and forget to ask what the vital signs are or why you came to the Met call in the first place. Ask the nurse what were the vital signs when you called the Met call, and continue to check them. If there are deranged vital signs, do they need treatment immediately? So if you come across a patient who has an elevated respiratory rate, if they have any work of breathing or they have any hypoxia, obviously apply oxygen straight away. Hopefully by the time you get to the Met call, that will have already been done, but not always. So if the patient's not on oxygen and you think maybe it would help, then put some oxygen on. And that can be just nasal prongs, or it can be a Hudson mask if you're at a Met call. If the patient has an elevated heart rate or a low blood pressure, there's very little to lose in considering a fluid bolus. Most patients with shock will respond well to a fluid bolus, if they're going to respond at all. It's very rare to do more harm by giving a small fluid bolus. So starting off with some fluid is always a good approach. And if the patient has a temperature, make sure you do expose them and check for a source of infection. I always tell everybody who's sort of new to coming to Met calls that if you are concerned about the patient and you don't feel there's enough attention being given to the patient, or there's not enough people in attendance yet, don't be afraid to upgrade to a code blue. You can do that just on the basis of clinical concern or the fact that you need more support. And no one's ever going to yell at you and say you shouldn't have called a code blue. So if you turn up and you see the patient and you say that patient looks shocking, I think actually we should call code blue because I'm not willing to wait 5 minutes for the ICU registrar to get here, then just go ahead and do it. At the end of this assessment, so your initial history and initial examination and assessment of the vital signs, you should be able to answer the question, is the patient shocked? It's really important, as we identified at the start of the talk, to say whether the patient is shocked or not, because you need to get everybody on the same page as to how urgent it is to treat that patient. And of course, repeated assessment is essential. So even if when you turn up, the patient doesn't appear to be that shocked, if they're deteriorating, you need to repeatedly go back and reassess those things and see, have they actually changed state since the first time that I examined them? Investigations in the patient that you think might be shocked. So obviously, bloods is important. If the patient hasn't recently had bloods, then you should send off a full blood profile as well as a blood gas. And if you have any respiratory concerns, try to get an arterial blood gas, but don't let it delay other management. The only reason to do an arterial blood gas really is to see what the patient's arterial oxygenation and CO2 are. All other values can be identified on a venous blood gas, which is often much quicker to perform. If you have any reason to believe the patient might be bleeding, or if they might need surgical intervention, then you should definitely consider a group and hold. If the patient appears to have a distributive type shock, then you should consider taking cultures, either blood cultures or cultures of a specific site of potential infection. And of course, if the patient is cold and shocked and you're not quite sure why, then always consider cardiac investigations. And in particular, if they have any history of cardiac disease or chest pain. I think an ECG should be done in every patient who presents with shock, not only because the patient's likely to be tachycardic, and so it's important to get the ECG to make sure that they're not in an arrhythmia, but also because it's really important to identify if there is any cardiac impairment going on. If the patient has cardiac ischemia, then that needs urgent treatment. So it's always important. However, ECGs can take time to get on the wards. Sometimes there's no ECG machine around. It takes a while to get, takes a while to hook up and get done. And sometimes this is done when other priorities actually should be followed. So in a patient with distributive shock who clearly is hypertensive because they have sepsis, then it might be more important to get your nursing staff to go and get the antibiotics and the fluids rather than to send them off getting the ECG machine, if you think that that can wait until after the patient's had a bit of resuscitation. Bedside echo is always useful, but there's not always someone who can do it. But if there is, then it's always a useful test. Then there's advanced tests that can be done for patients who are presenting with shock. And these are things to consider after you've done the initial assessments, investigations, and any resuscitation that's necessary. And that's things like imaging to identify a source of infection or a PE or identify a source of bleeding, or moving them onto an intervention. So things like scopes for bleeding, coronary angiogram if they're having cardiac ischemia, or surgical intervention if they have a perforated ulcer or something like that. It's really important though with these advanced tests, they do have a think about whether it's suitable to move the patient for those tests. So sometimes the patient will be so unwell that they need quite a prolonged period of stabilization before they're safe enough to take for imaging or other investigations. So when we're talking about this initial management of shock at the bedside, you might be wondering, like, this all sounds good and well, but like, what can I actually do at the bedside, and what sort of is the accepted way to start to treat shock in the initial instance while you're still getting the investigation sorted and waiting for those test results? Obviously, the first thing is to put the gloves on the right way. I'm terrible at putting on gloves all the time, but particularly when other people are watching and you're in a hurry. Always size up on gloves, I think, if you're stressed and in a hurry. That would be my piece of advice. But the initial management of shock is based around these key principles. So you want to make sure the patient is well oxygenated. You want to make sure they have good IV access. They receive volume resuscitation. They receive early vasoactive supports if that's what they need. That you manage the underlying cause and monitor in the appropriate setting. So it's always important with a patient with shock that you don't leave them. It might be tempting to run off and do something else, but it's really important that you stay with the patient in shock. Improve tissue oxygenation by supplying oxygen if needed, and think about early escalation if you think ward-based oxygen is not going to be sufficient. Make sure you have 2 large bore IV access, but if you can't get large bore access, get anything. You can't give IV medications if the patient doesn't have an IV, but you can give IV medications through a small bore IV access. So anything that you can get is helpful. Volume resuscitation with the goal of normalizing the blood pressure, and boluses of 250 to 500 mils at a time, and assessing the response to that bolus. You could give up to 2 liters unless the patient presents as fluid overloaded, but beyond that, you might want to start thinking about vasoactive supports. This is where your ICU colleagues come in, and vasoactive supports are given with the idea of normalizing either MAP or the cardiac output. So that might be IV medications that increase systemic vascular resistance in those distributive shock patients, or increase cardiac contractility, such as in patients with cardiogenic shock. Unfortunately, those need to be given in a CCU or ICU setting, so that's when you need to start thinking about where you're going to monitor and manage the patient going forward. And then, of course, managing the underlying cause. The shock is not going to get better until the cause is addressed. So don't forget to treat the actual problem. Make sure with your septic patient you're getting the antibiotics in early. Make sure with the bleeding patient that you're getting them on the way to some sort of intervention. And then monitoring, you might need to consider invasive monitoring, and you might need to consider moving them to a highly monitored area. Last piece of advice for addressing shock at the bedside is don't ever forget the goals of care. Sometimes the right thing to do is nothing at all. Not all patients are suitable for all forms of support. for their shock state. And in fact, their shock state might be a sign that they are either already on a pathway to dying or they're at a state in their disease where further intervention would cause more harm than good for them. So always think about what the patient's values are and what's important to them, and whether the interventions that you provide will actually provide meaningful recovery to a level of life enjoyment that the patient would find acceptable. And so whilst you're getting everything else sorted, it might be worth having a look to see if the patient has goals of care already identified, or having a talk to the treating team or the family about any limitations to care. There are more advanced approaches to shock management. So in particular, and most of these are provided in the intensive care. So for hypovolemic shock, you might be thinking about massive transfusion, and you need to communicate that directly with the blood bank. But also vasopressors in the patient who's very hypovolemic. Whilst you're giving volume resuscitation, you may also need vasopressors to support the blood pressure. They don't fix the hypovolemia, but they do help with supporting the blood pressure and preventing organ impairment while you're doing fluid resuscitation, and also with any subsequent distributive shock that develops after you've given lots of blood products and pro-inflammatory elements within those blood products. Then the patient develops a distributive shock that might need vasopressor support. For cardiogenic shock, you might need inotropic agents, but these usually require central venous access. And more advanced techniques would be things like an intra-aortic balloon pump, which is inserted by a cardiology or a surgeon, or ECMO, for which we need to contact the Victorian ECMO service. These are very advanced treatments that would only be instituted in very specific cases and under the guidance of either cardiology or the intensive care. For obstructive shock patients, inotropic agents can be helpful, but the definitive management would be drainage or thrombectomy or thrombolysis or myomectomy or whatever is required to reverse the obstruction itself. And again, ECMO might be needed to support these patients in the interim. And then distributive shock, vasopressors are very useful and important in distributive shock, and often very high doses will be required, and that will again require central venous access and admission to the intensive care. Continuous renal replacement therapy for any AKI or for the management of inflammatory mediators is sometimes instituted, but of course, definitive management is source control, getting drainage and washout done. Okay, so I want to stop there and just see if anybody has any questions, comments, or concerns, and then we're going to move on to just a couple of brief case studies so we can just put some of that into practice.
So we've got a question from Dylan, who's asking which vasopressors can be given peripherally and which centrally.
Sure. So in terms of vasopressors, so the main one that can be given peripherally is metaraminol, which you might come across if you do anesthesia. It's very commonly used there. Or you might come across in a little syringe given as bolus doses at met calls. Metaraminol is a great introductory vasopressor, but it's not that powerful. And so in patients with progressive or deteriorating shock, they often will reach a maximum dose of metaraminol and need to advance onto more powerful vasopressors such as noradrenaline. But all of those other vasopressors require central venous access. However, the caveat to that is that in a patient who is dying of shock, anything can be given peripherally. So whilst the risk, if that medication extravasates, is that you could get local skin necrosis and injury to that limb, and potentially the patient might lose the hand or the fingers or part of that limb if that were to happen. If you're doing that in order to save the person's life, then that is justifiable. So you will often see patients come in from the ambulance, for example, on peripheral adrenaline, which is an inotropic agent, but similar to noradrenaline, can cause skin necrosis and can be very severe if it extravasates peripherally, and usually is given through a central venous line. But the ambulance uses that as their first line agent because it's most likely to help save the patient's life. So if you do have a patient who requires vasopressors, don't be afraid to start vasopressors, even if it's more advanced than metaraminol, through a peripheral line. Try to make sure it's a big and proximal peripheral line. that's well placed. But then as soon as you're starting that, you should be thinking about how am I going to establish central venous access for this patient. So it's all about, how long am I willing to accept that risk to the patient before I can get in some central venous access. Any other questions? No?
I think that's it. Thank you.
Great. Okay. I don't actually know what the time is. Oh, gee, it's really late. Okay. So we'll go really quickly through these case studies because I don't want to hold people up for too long. So the first case study, we've got a 30-year-old female presents to the emergency department with fever, nausea, and flank pain. On examination, her vital signs, she's got a tachycardia that's regular. She's maybe borderline or mildly hypotensive, a little bit of an elevated respiratory rate, and a temperature of 39.5. She feels warm when you touch her. She's a little bit irritable, which is out of character for her. Is she sick? Could she be in a shocked state? Obviously, the answer here is going to be yes. What treatment would you commence immediately for this patient? Does anyone have any advances on that? And these are not trick questions. I just want you to sort of be talking through what we've already talked about, the approach to the investigation and management of these patients.
So some suggestions are fluids and broad antibiotic coverage. So some people have suggested ampicillin and gentamicin. The one person's said vasopressor. Mm-hmm.
Yeah, okay, fantastic. So you've hit some of the important points there. So your management priorities in this patient are you want to get some volume resuscitation into them. You want to think about early vasopressor support. And again, you want to treat that underlying cause. So early antibiotics is really important in this patient. What investigations do you want? So in particular, you want to be looking at the full bloods, looking for those inflammatory markers, and also doing cultures for anything that you think might be infected. In this particular lady as well, she's presented with flank pain. So you want to think about, well, if she has flank pain, could she potentially have an infected obstructing stone? So you might want to think, do we need an ultrasound or a CT scan to look for that? Because that's something where we could actually do an intervention for source control. So this lady has presented in septic or distributive shock. And sepsis is defined as a life-threatening organ dysfunction due to a dysregulated host response to infection. Organ dysfunction is defined as the specific increase of 2 points or more in the SOFA score. But in clinical practice, we're not walking around calculating people's SOFA score. We're looking at the patient and seeing if they have organ dysfunction as a result of infection. Septic shock, if we're talking specifically about the shock state, is sepsis plus both of hypotension requiring vasopressors and an elevated lactate. And with these criteria, unfortunately, hospital mortality for septic shock is in excess of 40%. Sepsis is a leading cause of death, and it is a time-critical medical emergency, as time to treatment, and in particular time to antibiotics, is associated with the outcome for these patients. In terms of management, we want to start with oxygen as part of our general shock management, establish good IV access as part of our general shock management. And then we want to focus on the cause, so taking blood cultures, looking for that cause and checking what the lactate is to see how severe the shock is. And then that resuscitation with fluids and early vasoactive supports. Early antibiotics and early source control is really important in these patients, and then monitoring and escalating if they're not responding. So often these patients will sit in the emergency department and have 2 or 3 liters, but have a continuously low blood pressure. Those are the patients where probably they could have started earlier vasoactive supports whilst ongoing IV fluid resuscitation is occurring to try to protect that blood pressure and prevent further organ dysfunction. Our second case study is a 72-year-old man admitted to the ward. He came in yesterday with functional decline and confusion. There's been a MET call for nurse concern regarding his large episode of melena, and you turn up. He's got a heart rate of 55, a borderline blood pressure. He's on a little bit of oxygen and he's slightly on the hypothermic side. When you examine him, he's cold and pale, he's confused, he has multiple bruises. What specific information are you trying to find from the history for this gentleman?
So some of the responses that we've got so far, we'd like to know whether the patient's on blood thinners and whether there's any evidence of blood loss.
Yeah.
How long has the patient been having melena?
Yeah, exactly. So you want to know from this history, is the patient on anticoagulation? And you might find out that they were on warfarin until they presented to hospital. And like you say, how long have they been having melena? How long has this bleeding been going on for? Do I need to be concerned that they've lost a lot of blood already and they might be going into hemorrhagic shock? And then the other thing to think about with a patient who's got an abnormally low heart rate in the setting of what you think should be a heart rate elevating insult, such as bleeding, is this the patient on some medication that's preventing their heart rate from going up? So in this case, you might find out that this gentleman is on a beta blocker, and so he can't mount a tachycardia to increase his cardiac output. What bloods do you want to send urgently on this gentleman? So obviously you want to be looking at their coagulation profile, in particular if you know the patient's on anticoagulants. But even if you don't know, or you know that the patient's not on anticoagulants, you still want to see the coagulation profile because you want to see if they might be developing something like a DIC with a low fibrinogen and a coagulopathic state that might exacerbate their bleeding. And then secondly, you must make sure this patient has an active group and hold. Is this patient shocked? I think we could safely say that he's not looking very well, and clinically he meets some of the criteria for shock. He's cold, he's confused, and we know that he has a potential cause for shock. The blood's come back with an INR of 6.1 and a hemoglobin of 78, and he's got an acidemia. You come back from checking these bloods on the computer and the patient has vomited bright red blood all over the floor. What are your management priorities at this point?
So one suggestion is stop the bleeding, secure the airway.
Mm-hmm. Yeah, so I think, yep, go on.
I was going to say another suggestion is calling a MET call and taking some blood for a group and hold.
Absolutely, yeah. So exactly, hopefully by this point, the patient's already got a MET call and there's already enough people, but if there's not and you need more support, then definitely call for more support. This patient is actively bleeding and is coagulopathic as a result of their warfarin. And so this is an urgent situation and the patient also has a shock state. So this is a critical situation and you need to have lots of people ready to go and helping your management, because there's actually multiple management priorities competing with one another here. One is going to be a reversal of the coagulopathy and in particular reversal of the warfarin. Two is going to be finding the source of bleeding and stopping the bleeding. And three, as you say, is going to preventing complications. So things like managing the airway if you're concerned about this patient potentially aspirating, or preventing organ dysfunction by making sure that their peripheral perfusion and organ perfusion is adequate. So you've got lots of management priorities to think about here, and you're going to need lots of hands on deck to get everything done. Who would you call first in this circumstance? You're at the MET call and you've got 3 of your co-interns there with you, but you're all looking for something to do. Who are you going to call? Who are the people that you need to get on the phone with and get some advice?
Call ICU.
You go, Matt.
Oh, so some specialties that people have suggested are surgery, ICU, gastro. Someone suggested AGSU, which is a general surgical service that the Northern has. Some other hospitals might have a different name for it.
Yeah, exactly. So I think what a lot of you have pointed out there is the first thing you need to do is probably call someone who can intervene with the bleeding, because you really need to stop the bleeding. And whilst you can do medical management for the coagulopathy and everything, if the bleeding source is not controlled, then even if you reverse the coagulopathy, you won't necessarily reverse the bleeding. So my first port of call for this patient would be gastroenterology. And if they say, no, actually, I think this is a surgical bleed, then surgeons. And if they say, no, actually, I think this is something we should manage with interventional radiology, then the next one would be interventional radiology. So you want to get some plan in place immediately to get the patient somewhere where the source of bleeding can be controlled. The next thing would be talking to anybody that you need to talk to in order to get the patient to that place. So if the patient's going to go to theatre, then you need to get anaesthetics involved early and say, this patient's going to come down to you. I need you to come and assess the patient and help to take them down and prepare them for their procedure. And the other one would be the on-call hematologist, because you want advice about reversing the warfarin and what blood products to give, particularly if you're activating a massive transfusion, which I think in this case you probably would be. Some of you have suggested calling ICU. I think honestly that whilst I'm chuffed that you want to call us, it's probably further down your list of priorities. And that's only because ICU is fantastic, but they can't reverse things like bleeding. All we can do is try to support the patient, and definitely we might have to be involved in this circumstance, but we can't actually stop the bleeding. And we're not specialists in hematology, so we can't address the warfarin. So whilst we can absolutely provide support and try to help the patient and prevent them from deteriorating further, you need to get some of those management priorities started first before you are picking up the phone to call the intensive care. In terms of calling the on-call hematologist, I think the main things you want to ask them is about the warfarin reversal. So principles of management are similar for any other type of shock. So you want to do your doctor's ABCD assessment and establish IV access, resuscitation with blood, with the purpose of restoring perfusion and oxygenation. And if you think the patient's going to need more than 2 units of PVACCS cells, so if they're actively bleeding, they're coagulopathic, they're vomiting blood everywhere, and they're hypotensive already, then I'd say they're probably going to need more than 2 units of PVACCS cells. Then I would activate a massive transfusion protocol. And that can always be stepped down again, but it's better to activate early so that the blood bank is on board with getting you the products as soon as possible. Reverse the coagulopathy and prevent further coagulopathy by managing things that affect coagulopathy, like the temperature, any acidosis, the calcium level, and the platelets and coagulation factors, and then stop the bleeding. So whether it's gastro, surg, or interventional radiology, or even a bedside balloon tamponade, there needs to be a plan in place immediately to stop the bleeding. And then monitoring, which this is where you might be thinking about the intensive care. Does the patient need an arterial blood pressure line? Do they potentially need vasopressor support while we're giving them blood transfusion resuscitation? If the patient has been to endoscopy, the bleeding source has been treated, the patient remains hypotensive afterwards, their lactate's not coming down, and then you do an ECG and you're worried about some new changes, what you might be thinking is going on there is that they've actually developed some cardiac ischemia as a result of the hemorrhagic shock. And so that's just to say that different types of shock can evolve into other types of shock. It's actually very common for different types of shock to coexist together or to follow one after another. So just because you've identified one type of shock doesn't mean the patient might not progressively develop another type. Okay, take-home messages, because we're way over time. So shock is a medical emergency. It will lead to death if left untreated. So never walk away from a patient with shock, and make sure you're starting to practice that concurrent investigation and management. Always consider if there might be a mixed shock state and there might be multiple different shock etiologies that you need to manage. And escalate early for definitive treatment of the cause of the shock and advanced supports to help the patient stay alive while you're treating the cause of the shock. And finally, don't be reassured by normal results. If the patient looks unwell, trust your gut and make sure you escalate to someone else who can also assess the patient. Okay, we'll leave it there. Sorry to go way over time, but does anyone have any other questions they'd like me to answer? I'm more than happy to answer them.
Given things have gone a bit over time, I think maybe if people want to quickly yell out if they'd like to talk to you directly, if there's any really pressing questions. There's just a couple of thank yous. Otherwise, if you have any questions, feel free to message us at PVACCS, and I'm sure we can forward them to Emma if she's happy to receive them, and we can get back to you. A recording of tonight's session will be available, as always, on our PVACCS YouTube channel, so feel free to watch and rewatch. I hope everyone has gotten a lot out of this. I certainly have. It's been an absolutely fantastic talk, Emma. We all really appreciate it. We're getting a lot of thank yous. If no one has any really pressing questions, I think we probably should end there and go have some dinner.
Thank you very much, guys. Thanks for having me. Sorry again for going over time. It's a common mistake that I make. And yeah, if you do have any questions, just reach out to Matt and he can pop you through to me, and I'm more than happy to answer them offline.
Okay, beautiful. Thank you very much, everyone. And thank you, Emma.